So now we see whether Michael Belin is on.
I'm online.
Hello, Michael. How are you?
I'm doing fine.
You,
So I would say Guten Tag, but for me it's Guten Morgen.
So it's in the middle of the night, isn't it?
It's the middle of the night or the middle of the morning, depending on how you look at things. Yes.
Well, what time is it there in Arizona?
It's now 4 in the morning.
4. Oh, thank you very much. We highly appreciate that, and we never do that again with you.
I'll never accept again. I'm kidding.
You thought to be in Hungary.
So, yeah, they would not allow me in. As you know, the EU has closed a lot of travel from the US. So should we get started? You all can see my slides, correct?
Yes. So you talk about the objective measures for the determination of ectasia progression. Thank you very much for having
Correct.
you.
So the first thing I usually get is, why do we need a new system? And I know Renato made reference to the global consensus that was published in 2015. And again, this was a consensus document of the 4 multinational cornea societies: Asia Cornea, Eucornea, Pan Cornea, and the Cornea Society. And what they conclude about keratoconus progression, well, they defined ectasia progression by a consistent change in at least 2 of the following parameters. And what was key is they said where the magnitude of the change is above the normal noise measurement of the testing system, and at least 2 of the following: steepening of the anterior corneal surface, steepening of the posterior corneal surface, or a thinning and or increase in the rate of corneal thickness change from the periphery to the thinnest point. And again, those changes need to be above the inherent noise variability of the measurement system. I always get a question, well, why do we need a progression display? Can't we just follow the final D from the bad display? Well, can't we just follow the parameters of the ABCD staging or grading system? Well, the Belin ambrosia or enhanced display was designed specifically to separate normal from abnormal. The final D shows a variance from normal, but not necessarily keratoconus. And what do we mean by that? Well, if you look at the lower left picture, this is a post-refractive case. It's obviously not going to be normal. There's an abnormal final D, as it should be, because it's not a normal cornea. The upper right picture is hyperopic LASIK. Again, if you look at the anterior surface, it mimics keratoconus. We'll have an abnormal Belin ambrosia display, as we should, but again, it's not keratoconus. The lower right is endothelial dysfunction. Again, if you look at the PTI graph on the lower right part of that lower right map, you'll see a flattening of the PTI graph because you lose the normal change from going the thinnest to the periphery. Again, an abnormal cornea, but again, not keratoconus. So why a new progression display? Again, as I said, the bad display was designed specifically to separate normal from abnormal. It's very useful, but not necessarily specific for ectatic disease unless we add a few additional parameters. It was designed, as I said, as a risk analysis for refractive surgery. It can be used as one of the inclusion criteria for keratoconus studies, but not by itself. And again, the final D shows deviation from normal, but not necessarily progression of disease. As you will see later, the ABCD progression display was designed specifically to follow and document progression of disease. It is based on a one-sided confidence interval, which we'll go over later, and allows for documenting progression in spite of a stable anterior surface and a stable K max by evaluating each anatomical layer individually. Well, the other question is, why can't we just follow the ABCD staging or grading parameters? Well, the ABCD display was designed really to follow population-based studies, not really to follow an individual patient. And what do we mean by that? Well, if you look at that lower right picture on body mass index, another grading system. Let's look at the green, so-called normal, which goes from 18.5 to 24.9. Well, someone can come in at 18.5 and change all the way up to 24.8, a huge change, but their grading would still stay the same. In this case, it's color-coded green. Another individual can come in at 24.9 and just go to 25, a very small change, but would jump a whole grade. So gradings are really designed more for population-based studies, not really to follow individual patients. If we look at all the prior progression parameters and look at this entire list, and I don't know if my pointer shows or not, other than pachymetry here, every single one of these parameters is anterior surface based. So again, in the past, every single parameter that we use for progression of keratoconus other than pachymetry was an anterior surface based parameter. But we need a whole new way to look at progression. And the reason for that is, and we still do, our reliance on Kmax as both an efficacy parameter and as an indicator as progression has resulted in delay of treatment. In other words, irreversible loss of vision, and did not allow us to intervene at the earliest possible stage where we can actually detect progression. And I think most of us now do know that Kmax in itself is a relatively poor parameter, both to determine, again, treatment efficacy and clearly determine when and if we have progression at the earliest possible stage. As I said earlier, the Belin ABCD progression display was designed specifically to follow and document progression of disease. It's based on one-sided confidence intervals because we're only interested if the cornea thins or if the anterior and or posterior surface steepens. It allows for documenting progression in spite of an anterior surface that's stable or a stable Kmax. And it's based on the ABCD parameters. And the A parameter, what's important about it is that it's not an apical parameter. It's the anterior radius of curvature taken from a 3 millimeter zone centered on the thinnest point. So as opposed to, let's say, a standard measurement of pachymetry, which is apical based, these measurements are based on the thinnest point, which corresponds usually to the cone. As opposed to Kmax, which is a single point, the A parameter anterior radius of curvature is taken from a 3 millimeter zone. B is for back or posterior radius of curvature, again, taken from a 3 millimeter zone centered on the thinnest point. The C is the minimal corneal thickness, not again an apical reading. And D is best spectral corrected visual acuity. It is not an objective measurement, so it's not part of the progression display other than just showing it, but it doesn't enter into the analysis. The A and B parameters are actually new parameters, and because of that, we needed to determine the inherent noise for each of these parameters. If you remember again the global consensus, it was a statistically significant change above the normal measurement noise of the system. And we devised, again, a progression display that will automatically determine stage and when and if you obtain a significant change. We also decided it was important when we initially did this to determine the noise levels from two different populations, both a normal population and one with moderate to advanced keratoconus. And why was that? Well, for your older patient or your patient with clinically evident keratoconus, the noise levels from the keratoconic patient database would be the appropriate ones to utilize. And we all know that patients with abnormal corneas, particularly keratoconus, inherently have more noise in their measurements. Additionally, an older patient with keratoconus is less likely to exhibit the rapid change we see in the younger patients, so the risk of waiting is lower. For your young patient, however, or those with very early or subclinical disease, they may have a more rapid change. And the noise measurements, and again, in the young or the very early cases, more closely matches a normal population. In addition, the younger patient with normal vision and subclinical disease, it is paramount that we detect change as early as possible to avoid loss of vision. Here, the risk of waiting is higher. And it's not important that you look at these numbers particularly, but again, as I said, we looked at both standard deviation and one-sided confidence intervals. We determined both an 80% one-sided or one-tail confidence interval and a 95%. And if you look at the numbers, the red ones were the keratoconic population, the greens were the normal, and as you would expect, the keratoconic noise levels are higher across the board than we see in the normal population. I want to stress that the progression display is only one bit of information. You need to also consider age, visual acuity, family history, status of the other eye, whether they rub their eyes, etc. But again, it's one bit of information for us to look at. And this is what the progression display version 2 looks like. About a month ago, which we will get into later in the talk, we released iteration 3. But what this shows you, it allows you to display up to 8 exams over time. It displays graphically both the A parameter, the B parameter, the C parameter, and the D parameter, but only the ABC, which are the objective measurements, have confidence intervals. The system will default to show you both the normal, shown in green, confidence intervals and the keratoconic, shown in red. The 80% confidence intervals are shown by a dashed line, the 95 by a solid line. And as you can see, as we would mentioned earlier, the keratoconic confidence intervals are always larger than those in the normal. So again, the reds will always be larger than the green. In addition to the graphical analysis of the ABCD, we also show you on the bottom in tabular format a number of other parameters that you can follow if you're interested. These include the ABCD classification, the BAD-D, the progression index, all the anterior surface parameters, as well as Q value and K max. The display will default by identifying your first exam as baseline. That's shown by that upper left green arrow, but you as the operator can opt to choose any exam as baseline, but again, it will default to choosing the first exam as your baseline exam. On the right side, you can show when you've done a treatment. In a treatment here, we're really talking about cross-linking. The display will default to show you both the green normal confidence intervals and the red keratoconic, but you can choose to show one or the other. But again, it will default to showing both. Here's an example. It's the same patient, but in the upper we've chosen the normal population only. In the lower, we've chosen the keratoconic population only. It actually makes it a little bit easier to see if you just display the confidence intervals that you're going to use clinically. but again, the system will default to showing both. And again, as we already said, if you compare the upper and lower, you'll notice that the red gates are all further to the right, again, inherently more noisy than the green, quote, normal noise levels. In the second iteration, once you've indicated that you've done a treatment, and again, here we're talking about cross-linking, all the confidence intervals will no longer be shown after the treatment because the noise levels post-cross-linking were not determined. So here you can see again, we have 5 exams, but 3 exams after the cross-linking treatment do not have any confidence intervals associated with them. So let's look at a few examples, clinical examples. This is a 15-year-old with advanced keratoconus with a 7-year follow-up. And it's difficult for me to see my screen. Hopefully it's a larger screen for you. But if you look down at Kmax, you'll notice an increase throughout the period of Kmax. And if you look at the A, B, C, D parameters, they can consistently increase. So here we see that the A, B, C parameters match very closely to Kmax, but that's not typically what we will see. So let's look at the next example. This is a 15-year-old with very early keratoconus. You can look at the D values, they're roughly 2 to 3. And if you look at the far right, I've blown up the Kmax values. They go in a 13-month follow-up, they go from 46.1. The next exam was 45.5. The next one was 45.8. So this does not meet standard criteria for progression of a change of 1 diopter. So again, in most countries and in the US, we would not be approved to treat this patient. And if we look at the A parameter, we'll notice there's no significant change in the A parameter. But look what happens now on the B parameter. Even by the second exam, we're past the 80% confidence interval, and by the third exam, we're past the 95%, way past the 95% confidence interval. In other words, progressive posterior ectasia in spite of a stable anterior surface. In a young patient, this is an indication to treat, to intervene before they get changes on the anterior surface, which are associated with a loss of visual performance. This is a 16-year-old with progressive subclinical disease. If you look at the Kmax, again, blown up on the far right, 48.9, next 49.8, just below the criteria in most countries. But look what's going on in the progression display. The A parameter by the second exam is well past the 95% confidence interval for the green, well past on the B parameter, and well past on the C parameter. Every single parameter here is past the 95% confidence interval, in spite of a Kmax that does not yet meet criteria. Again, this is an indication to treat, to prevent loss of vision. It's not just early or subclinical disease. This is a progressive advanced keratoconus. If you look at the D values, they're above 7. And if you look at the K values, Kmax, again, no significant change in advanced keratoconus. And again, if we look at the A parameter, it all is below the 80% confidence interval, no significant change. But if we look at the B parameter and the C parameter, we see change on the B parameter past the 80% confidence interval and on the C parameter past the 95%. What is my normal criteria determining progression? It's any single parameter beyond the 95% confidence interval or any 2 beyond the 80. So again, for those of you who do your math quickly, 2 parameters at the 80% confidence interval is very closely similar to 1 parameter at the 95%. So what has this told us about diagnosing progression of keratoconus? Well, we know there's a dissociation of clinical progression with changes in Kmax. We now have a tomographic-based classification system that looks at all anatomical layers and a tomographic-based progression display that documents when we have statistically significant change. Excuse me. And again, you can actually go back and look at your historical files with the new software. But how do we define progression after cross-linking? As I said earlier, the progression parameters after cross-linking have been unknown. And in version 2, the confidence intervals are removed after you indicate a cross-linking treatment. So in conjunction with the Homburg Keratokonus Center and the Elser Institute in Switzerland, we did a post-cross-linking progression study. We measured the noise of post-cross-linking eyes to evaluate whether these measurements can serve as progression determinants for, again, analysis after treatment. We used 2 sites in this study as opposed to our earlier, which was only 1 site-based, because cross-linking is a surgical procedure with inherent user or site variability. We took 3 separate Penacam measurements after removing the patient between each exam. We had a minimal coverage of 7.5. Again, realized the ABC parameters were only looking at a 3 millimeter optical zone. And we computed both pooled variance and one-sided confidence intervals. We looked at site-specific and time-specific comparisons. The far right table there shows you what the confidence intervals were. And interestingly, what you will see is that the post-cross-linking noise levels or confidence intervals actually fall in between the normal green and the keratoconic red. We looked at a total of 60 patients. 38 were from Zurich and 22 were from Hamburg. The age was very similar between, average 29.5 with a range of 11 to 62, and was similar between both Zurich and Hamburg. But if we look at the last line on the left table, the time since cross-linking varied greatly. While it averaged 26.1, it averaged 16.6 in Zurich and actually 42.2 in Hamburg. The Zurich range was from 1 year to 28 months, while the Hamburg ranged from 16 months out to almost 10 years. We did a geographic comparison. Again, we mentioned earlier that we wanted to do at least 2 sites because, again, it's a surgical procedure that we're looking at. And when we did that between Zurich and Hamburg, the populations had similar ABC values. And if we look at the lower graph, they had similar noise measurements. Now, these graphs may not look the same, but that's because the Zurich had 38 patients evaluated, the Hamburg had 22, and these are not weighted graphs. So actually, these 2 graphs are almost identical if you were to weight them based on the N value. We did a time since cross-linking comparison. Here we limited it to the Hamburg 22 patients because we had such a long range of 16 to almost 10 years. We divided the first 11, which was 1 to 3 years, and we compared those to those that were greater than 3 out to almost 10 years. So here the N values are the same. There's 11 in each group. And here you can see that the graphs are almost mirror images. So really, once you got past 1 year, the noise measurements seem to be constant throughout a 10-year period. And this is what the third or the most recently released iteration of the ABCD progression display. Now here, if you look at it, it looks identical to the second iteration because here we're not showing a cross-linking treatment. And if you recall, on the second iteration, if you showed a cross-linking treatment, all the confidence intervals after cross-linking were removed. So here's a patient that's post-cross-linking. Again, you can see that we've indicated a cross-linking treatment by that black dotted line, but no treatment is past the 1-year period. And in the third iteration, the current display, the confidence intervals will only appear post-cross-linking after 1 year. Again, because the noise measurements were determined at least 1 year post-cross-linking. And the reason for that is we actually did an earlier study and the noise levels were not consistent prior to the 1 year period. So again, confidence intervals will not appear if your post-cross-linking dates are prior to one year. Here is again the new progression display showing again the confidence intervals in blue for the post-cross-linking, because here we have exams that do occur at least 1 year post-cross-linking. But again, you will notice the confidence intervals only are shown on the exams that are at least 1 year or later post-cross-linking. Now, the display can get very busy because here we're showing everything. We're showing the red, the green, and the blue. And you can make it become somewhat difficult to use when you have so much information. But what can you do with that? Well, first, this is an example of a 16-year-old, which we're only selecting the green gates because it's a young patient with very early disease, makes it again a little bit easier to see. So here you can see the patient did have progressive change, cross-linking was done, and here we have 2 exams post 1 year cross-linking. And again, you can see the blue gates, and here we have a good efficacy of the cross-linking treatment. You can even make it easier to analyze once you've done cross-linking treatments. We really are only more interested in the post-cross-linking, so you can select which exams to show. And here we're going to show, where we go, didn't change. Here again, we're only showing the 1 exam preceding cross-linking and then the post-cross-linking exam. So again, this is that same confusing display we showed you earlier, simplified with the clinical information that we're looking at. So again, here we're only showing 1 exam before cross-linking and then the post-cross-linking exams. Again, much easier to clinically evaluate. Here is an exam. Again, we're only showing the 1 exam before cross-linking and then the post-cross-linking exams. And here you can see again a good response to cross-linking, continued improvement. And here is an example of one that may need possible retreatment. Here you'll notice on the A parameter, by the 2nd exam that is more than 1 year out, we can see the A parameter is just about at the 95% confidence interval. If we look at the B parameter, that 1 exam, again, the last exam is at the 80% confidence interval. Now I will tell you, particularly on retreating, I will always require at least 2 repeat exams that show me significant change. And that's just really my bias. Here again, we've simplified that same exam and only showing the post-cross-linking, to which again makes it much easier to interpret. So while the system will default to show you all the information, you can select what you want to see. It makes it much easier to analyze the data. So again, here you can see again, we're only showing the post-cross-linking exams, much easier to interpret. So in conclusion, the post-cross-linking measurements, variance, or noise can be used to determine progressive change. While we only looked at 2 sites with relatively small numbers, a total of 60 patients, the noise measurements were consistent across the different centers. When we looked at the Homburger data, which included a very, very wide range up to 16 months out to almost 10 years, the noise measurements were consistent past 12 months. And as I said, we did an earlier study where the noise measurements, if we were before 12 months, really were not consistent. The post-cross-linking confidence intervals have now been added on the most recent iteration, which is version 3 of the ABCD progression display. And as I said, this was released, I believe, last month. I would like to acknowledge both the Homburger Keratokonus and the Elzer in Zurich, but also my co-investigators in Arizona. I want to thank you and appreciate you listening.
Michael, thank you very much for this excellent talk. I think You talked slowly and you talked loudly and clearly, and this is good for us because we really could follow you very well. And I would like to thank you very much for this indeed fruitful cooperation on keratoconus, which is not too typically made between the US Americans and the Europeans. So thank you very much for that.
What are you talking about? The Americans are always friendly. I'm kidding.
Maybe it depends on the Europeans.
I'm kidding.
When do we get the better version of the Belin progression display part 3? We don't have it right now.
It's been released already.
It's not released, it's theoretical.
No, it's released. It's been released for over a month already.
Is that right?
I can't talk to other countries. In the US, it's a free upgrade. You just have to contact Oculus, but I believe that's true throughout. So just so everyone knows, I do not get any remuneration for the software or displays that I develop. So this is just an academic interest. But there is, and there should not be any charge. It's just a free software upgrade.
And what I really like personally very much is your bold red cross over the Amsler-Krummeich classification.
Yes, I hate it.
I said that in the morning. My brain was not able to learn that by heart because it was so stupid. Now to the question from the audience. Why do we only cross-link progressive cases and not each young patient with the primary diagnosis of keratoconus?
So I know in many countries, if you have a young patient with a definitive diagnosis of keratoconus, they treat him on diagnosis. In the US, because of insurance companies, we're limited at the moment to progressive disease. There are, as you know, there are now a number of articles that have come out about the ABCD progression display showing that we can actually identify in progressive disease months prior than using Kmax, and we are submitting this information to the insurance carriers. Part of the other reason is epi-off cross-linking is not a totally benign procedure. So there is, a cost-risk, a risk-benefit ratio to look at. I think as we get more benign treatments and maybe an effective epi-on, I think you'll see people become much more aggressive and intervene at a much earlier stage. I do have to say that while I have no financial benefit from my displays, I am the Chief Medical Officer of CLXO, which is a epi-on cross-linking company in the US that's currently finished phase 2.
Thank you very much. And now I read a long text by Dr. Balvan. Thank you very much, Dr. Belin, for your very helpful insight into a challenging theme. Now, in the case of any condition that is progressive in the sense that correlated symptoms and or findings change over time, it does become relevant to both quantify and determine the nature of the change, which is to say to what extent such a change reflects a possible worsening of the underlying condition, especially in the case of disease. During signal measurement, the noise would have two components, one being the known component relating to the physics of the system, and the other being the less predictable algorithm-dependent noise added to the former, the algorithm being the machine algorithm for the ABC in the ABCD system, and the human algorithm in the patient when it comes to D. This covers the known unknowns we learn to live with. My question, how about the unknown unknowns, and is there a way to detect, suspect, or even figure out if, and possibly to what extent, these unknown unknowns may disrupt the relevance of a state-of-the-art measurement when determining progression in the context of corneal ectasia? Or is it the case already that unknown unknowns do not operate in the realm of cross-linking? And if yes, then how has it been possible to arrive at such a conclusion? Did you understand that?
Yes, I'm just surprised that this person had enough time during my talk to type all that, but that's So one is, and this is always the case, it's do we need to fully understand something before it becomes clinically useful? And usually the answer really is no. We have a lot of treatments for disease that we know are effective, but we don't really know why they're effective. As far as this goes, you are correct. Noise measurements have multiple components. As you mentioned, one is the inherent measurement of the system itself. Those tend to be very, very low. The greatest variable usually is patient-related noise measurements. I mean, if we take a perfectly smooth test object and repeat measurements on it, the noise is very low. In general, however, what we're really interested in is not necessarily knowing each component, but just knowing the total noise measurements. And that's what we looked at, which is the total noise measurements, which is the person asking the question is correct, is not a single variable. It's an inherent measurement in the system. It's an inherent measurement of the patient itself. But again, it's clinically what we want to use, which is a total noise measurement. I don't know
Thank you very much.
the question. I think my answer was shorter than the question, but
it was the other way would not be possible.
no.
Dear Professor Belin, thanks a lot for your great talk and for getting up that early to be with us. I have one question about the blue flags for repeated cross-linking. And do you use the same criteria for repeated cross-linking? That's in view of the confidence intervals. That's to say, one criterion surpassing the 95% confidence interval, or two criteria surpassing the 80% confidence intervals.
So first, the 2 at 80 versus 1 at 995, if you do the math, the 80% is really a 20%. So if we do 0.2 times 0.2, you end up with a 96% value versus 95. So again, two values at 80 are effectively the same at 1 at 995. I have, and no one has enough experience yet with the post-cross-linking display, which is why I said right off the bat, I would want to see at least two measurements that show me a consistent change. With that in mind, I think this actually maybe relates back to that that long question we had earlier. The parameter I am least comfortable with by itself is pachymetry. And the reason for that is when we do our noise measurements, and this does relate back to that earlier question, when we do our noise measurements, we're doing them basically the same time. We're just basically taking the patient and repeating exams. We know that pachymetry in particular does have some diurnal variation, and we typically don't examine our patients the same time every day. So as I said, I would want at least two measurements post-cross-linking because I think we don't have that much experience with it. And of the parameters, the one I would rely least on as a sole parameter is pachymetry, because again, our measurements were done at the same time of day for each patient, not the same time among patients, but each patient was just repeated within minutes. And when we compare exams over time, there tends to be a difference of time. And we know again that pachymetry can have a diurnal variation.
Michael, I think the anterior segment OCT gives you more reliable thickness measurements. We found that out, that the standard deviation of the repeated measurements was significantly smaller than with the pentacam. But of course, we cannot use that on a regular basis. So thank you very much for joining us in the very morning, and sorry for being late, leaving you waiting another half hour. And whenever you come over to Hungary, please stop by, land in Frankfurt. I get you from the airport, and then stay a day or two with us, and then fly on to Hungary. Thank you very much.
Thank you. Take care.
Have a good day. Bye-bye.
Thank you. Take care.